The part maneuver is a 4 progressive step maneuver that allows visualization of underlying structures and needling better. It consists of 4 steps, including P for pressure, A for alignment, R for rotation, and T for tilt. Let's have a look at some of these. In the first step, we apply a small amount of pressure in a vertical manner over the probe. This is typically done before insertion of the needle at the scanning stage. It can also be done continuously throughout later on if required. Applying a small amount of pressure allows for better visualization of the underlying structures. Too much pressure application can lead to patient discomfort and operator fatigue. On the other hand, a smaller amount of application of pressure may not be sufficient. In this demonstration of axillary scan, the axillary artery can be seen pulsating over the conjoined tendon. Release of small amount of pressure allows visualization of the underlying veins demarcated here by V. Therefore, continuous compression and release can allow for a better block. The next step is alignment. In this, the probe is brought closer to the needle. This is typically done after the needle insertion. Often once the needle is inserted, it may not be visualized appropriately. To correct this, look down upon your hands to identify the probe and needle alignment. Subtle movements of the probe to bring it close to the needle can allow visualization of some part of the needle. In this scan of adductor canal block, small subtle movements of the transducer allow for better alignment and visualization. The third step is that of rotation, and this can be applied continuously to make improvements. Small clockwise or counterclockwise rotations can allow for better visualization of first the shaft and then the needle tip. While we don't need to see the entire needle, the tip of the needle is quite important. Therefore, dynamic scanning and injection is paramount. In this scan of sciatic nerve injections at popliteal fossa, note how the entire needle is not visualized, but small rotation allows correct identification of the needle tip. Continuously applied and subtle corrections of rotation finally allows the entire needle, including the tip, to be visible. This is not always required, but at least the tip needs to be seen. The fourth and final step is that of a tilt. This is an optional step. A tilt could be caudal tilt or cranial tilt. Typically, this is not needed over flatter surfaces, however, is useful in 2 situations. One, when the area being scanned is curved, such as the supraclavicular fossa, while scanning the supraclavicular part of the brachial plexus, or when the underlying structure is anisotropic, for example, sciatic nerve in the popliteal fossa. In these circumstances, one plane that allows for better visualization of the needle tip may not be the best plane to observe the target structure, and therefore a dynamic scan between the 2 different planes may often be needed. Observe how in this scan of sciatic nerve in the popliteal fossa, the sciatic nerve appears better or worse depending upon the tilt given by the operator. This concludes the part maneuver, which includes 4 progressive steps: pressure, alignment, rotation, and tilt to improve visualization of the underlying structures and the needling while performing an in-plane needle block.